Welcome back to the Deep Dive. Today, we are taking on a challenge that would make even the most seasoned clinical professional pause. We're talking about mastering the interconnected systems that govern human metabolism and homeostasis. Imagine walking into a patient's room and realizing that their metabolic engine, their fluid balance, their blood sugar, their entire hormonal cascade, it's all potentially failing at the same time.
That high-stakes scenario is the reality. It's the absolute reality of acute medical surgical care. And this deep dive is sourced directly from a foundational text. We're talking Brunner and Sutter's Medical Surgical Nursing, the 15th edition. We are going to try and synthesize an entire unit that's focused on the very systems that regulate life itself.
So our mission today is pretty clear. This is a masterclass. We're going to extract that core clinical wisdom, linking the complex pathophysiology to concrete evidence-based nursing management. We're going to jump right in, detailing everything from assessment priorities to the specific patient education you need for these often chronic, yet acutely life-threatening disorders.
Exactly. And the overarching theme here is the comprehensive management of homeostatic and metabolic disruption. It's a huge topic. We'll start by defining obesity not just as a condition, but as a chronic relapsing disease. Then we'll move into the complex chemistry of the liver, cover biliary and pancreatic health, and finish up with those critical, fast-moving crises of the endocrine system. We're going to really break down the difference between DKA and HHS management. This material is designed to turn you into an expert guide through all this systemic complexity. Okay, you ready? Let's unpack this.
Let's do it. Let's start with Chapter 42, which it firmly establishes obesity in a new light. The sources we define it as a chronic relapsing disease. It's characterized by excessive body fat accumulation. And that's critical, right? Because it forces us to look past just lifestyle choices and recognize these profound biological factors at play.
Absolutely. The science recognizes obesity as a multifactorial disease. It's driven by behavioral, environmental, physiologic, and critically, genetic factors. When we look at the underlying pathophysiology, the core driver of all the resulting metabolic, biomechanical, and psychosocial disorders is something called adiposity.
Adiposopathy. It's a mouthful, but that formal name, it suggests that the fat tissue itself is sick, not just abundant.
That's it, exactly. Adipose tissue isn't just passive storage, it's an active endocrine organ. So when it becomes dysfunctional, that's adiposity, it starts releasing abnormal levels of adipokines, and that promotes chronic inflammation and metabolic derangement.
So that dysfunction is the crucial link, the thing that connects obesity directly to all those severe comorbidities.
Precisely. For example, the sources explicitly note that adults with obesity are not only at high risk for things like hypertension and type 2 diabetes, but they're twice as likely to be diagnosed with neurodegenerative diseases like Alzheimer's. It's a systemic problem.
Okay, so if this is a chronic disease requiring these complex interventions, risk assessment has to be multifaceted. What tools are nurses expected to use for a comprehensive assessment? It can't just be a simple scale reading.
No, not at all. The primary metric is still the body mass index, or BMI, which uses height and weight. We rely on the BMI thresholds detailed in Figure 42-3 of the text. So, overweight is 25 to 29.9 kilograms to a 5. Obesity class 1 starts at 30, and class 3, which is extreme obesity, is defined as a BMI of 40 or greater. It's a structured starting point.
But the sources make a really powerful case that the distribution of the fat is just as important as the volume, which brings us to body shape assessment, waist circumference, and the waist-to-hip ratio, the WHR.
Exactly right. Assessing waist circumference is non-negotiable. The risks for morbidity are significantly higher if a woman's waist is greater than 35 inches or a man's is greater than 40 inches. And then we analyze the shape, which is the whole apple versus the pear thing, android obesity versus gynoid obesity.
Android obesity, that's the apple shape.
Yes. And with android obesity, you have proportionally more visceral or abdominal fat stores, which is metabolically much, much more dangerous. We confirm this with the WHR. If it's greater than 0.90 for men or 0.8 for women, that suggests android obesity. That visceral fat carries a much greater risk for cardiovascular issues, hypertension, CAD, stroke, and of course type 2 diabetes. It's a big contrast with gynoid obesity, the pear shape, where fat is stored on the hips and thighs, which carries less risk. You can literally see the risk difference.
That distinction really moves us beyond a single number and into true risk stratification. So let's move on to management. Non-surgical approaches, they have to start with lifestyle, right?
Lifestyle modification is the absolute foundation. This means reduced caloric intake, usually a deficit of 500 to 1,000 calories a day, and physical activity. And the sources stress that even modest activity, just 10 to 20 minutes daily, is beneficial. Supportive dietary plans include evidence-based regimes like the DHH diet and the Mediterranean diet.
But here's where the nursing assessment becomes so critical, right? The medication connection detailed in Chart 42D2. We have to understand how pharmaceuticals for other conditions can completely sabotage weight loss efforts.
Oh, this chart is vital. It's vital for taking a thorough patient history. You absolutely need to know the categories of medications strongly associated with weight gain. This includes certain anticonvulsants like carbamazepine or valproate, specific SSRIs like paroxetine, and a lot of common antipsychotics like olanzapine. And critically, high on that weight gain list are diabetes medications like sulfonylureas and insulins, and of course, corticosteroids like prednisone. As a nurse, you have to educate patients on these side effects and discuss alternatives with the provider.
And then on the flip side, we have medications that actually promote weight loss. And some of them are now FDA approved specifically for anti-obesity therapy.
Precisely. Examples include toparmate, bupropion, metformin, and that whole increasing class of GLP-1 agonists. Which brings us to the next point. When do you actually initiate anti-obesity pharmacotherapy?
Okay, so what are the guidelines for introducing medication?
The medication is indicated for a BMI greater than 30 or a BMI greater than 27 if the patient has a weight-related comorbidity like type 2 diabetes or hypertension. The mechanisms really fall into two big groups. Either they inhibit GI absorption of fat, which can cause some unpleasant side effects, or they alter central brain receptors to enhance satiety or reduce cravings.
Let's look at two specific classes of drugs, the text details.
Okay, first we have the GLP-1 receptor agonists, like liraglutide. These mimic your natural incretins, so they cause delayed gastric emptying and they curb appetite centrally in the brain. The patient education piece includes how to do the subcutaneous administration and, importantly, monitoring for severe side effects like pancreatitis and potential thyroid tumors. Second, you have the sympathomimetic amines, like phentermine. These suppress appetite by stimulating central noradrenergic receptors. But the key nursing alert for phentermine, and this is a big one, is that it is only approved for short-term use, a maximum of 12 weeks. Because of the risk of dependence and its contraindications, particularly in people with heart disease or uncontrolled hypertension.
And all of that then leads us to the most durable treatment option for severe obesity, which is bariatric surgery.
Right. Bariatric surgery is indicated when other measures have failed. The procedures are classified by how they function. You have the Roux-en-Y gastric bypass, RYGB, which combines restriction and malabsorption, and that leads to some significant nutrient changes. Then you have gastric banding and sleeve gastrectomy, which are primarily restrictive procedures. They just reduce the stomach volume.
The text also mentions a really intriguing, less invasive investigational approach.
Yeah, the endovascular bariatric embolization. This targets the gastric fundus by embolizing the left gastric artery. Now, this area of the stomach is responsible for secreting the majority of ghrelin, which is the orexigenic or appetite-stimulating hormone. So the goal is to diminish ghrelin secretion. It's a fascinating, very focused approach to appetite control.
Let's break down the critical role of the nurse in the perioperative phase. This seems huge.
It is huge. Preoperatively, the nurse ensures the patient has realistic expectations, that they've attempted previous weight loss, and that they understand the absolute need for lifelong follow-up, dietary restriction, and vitamin supplementation. That's a lifelong commitment. Then, postoperatively, education centers on preventing surgical complications and managing this very strict dietary transition.
That dietary progression is so intense. Can you describe the sequence the patient has to follow to prevent complications like nausea and bile reflux?
It is extremely restrictive and it is slow. Patients start with clear liquids for up to 48 hours post-op, period. That's followed by full liquids, focusing on high-protein, sugar-free options. Next comes the pureed diet, then soft solids, and then finally, around 8 weeks after surgery, they transition to solid foods. And patients have to be taught to consume high protein, avoid high sugar to prevent dumping syndrome, and eat slowly, chewing everything thoroughly.
And when that strict regime is not followed, or I guess even sometimes when it is, we see this thing called dumping syndrome. What are the physical and systemic consequences of that?
Dumping syndrome happens when a hyperosmolar food bolus, so something very concentrated, rapidly enters the jejunum. This triggers this exuberant release of metabolic peptides, and that causes these acute and really dramatic symptoms, often within minutes of eating. We're talking intense pallor, cold perspiration, palpitations, dizziness, and this feeling of generalized warmth. Nurses have to recognize these symptoms, which can sometimes mimic hypoglycemia or an anxiety attack, and educate patients to avoid the triggers, especially high sugar and high fat items.
Dysphagia is another common issue, right? Especially with the purely restrictive procedures.
It is. Dysphagia, or difficulty swallowing, is pretty common in the first 6 months. Patient education here centers entirely on chewing thoroughly and eating very, very slowly. If the dysphagia persists beyond 6 months, the nurse should suspect a stomal stricture that might need endoscopic dilation. Oh, and another thing. The text warns patients must avoid all NSAIDs postoperatively to prevent marginal ulcers.
Okay, before we move on, let's circle back to that really challenging ethical case study in the text. It's about TN, the patient with class 3 obesity, who needs a strict 1,000-calorie restriction to heal a life-threatening pressure injury. But the staff suspects she's getting high-calorie food from visitors. The ethical conflict here is powerful.
It truly is. Because you're balancing the ethical principle of autonomy, TN's right to choose what she consumes, against the principle of beneficence, which is the nursing obligation to enact the prescribed therapeutic regime, which is essential for her wound to heal. The nurse is put in this incredibly difficult position. Enforcing the diet might accelerate healing, but resistance risks malnutrition and psychological harm.
And the suggestion from the charge nurse to screen visitors, that really raises the boundary question.
It does. Screening visitors infringes on TN's right to privacy and her confidentiality regarding her treatment plan. The textbook analysis suggests the nurse's primary role here is not coercion or surveillance, but a risk analysis. Does the potential benefit of rapid wound healing via strict enforcement outweigh the risk of emotional trauma, non-adherence, and resulting malnutrition? The professional action is to advocate for TN, assess her readiness to change, and mobilize support resources, rather than setting up this adversarial relationship based on, food monitoring.
Okay, that's a huge transition from long-term lifestyle management to the acute complexities of liver. This is a serious jump. The liver is the body's largest gland and our central chemical factory.
It is indeed. And the liver is unique because it receives nutrient-rich blood directly from the GI tract through the portal vein. Its metabolic roles are expansive. It's responsible for glucose metabolism, storing it as glycogen, glycogenesis, breaking it down, glycogenolysis, and making new glucose from amino acids, gluconeogenesis. And it also synthesizes crucial proteins like albumin and all your clotting factors.
I find the cellular security system inside the liver just fascinating.
You're talking about the Kupffer cells. Yeah, these are massive fixed macrophages. They're the most common phagocytes in the entire human body, and their job is critical. They patrol the sinusoids, engulfing and destroying bacteria, foreign particles, and any debris that enters the liver via the portal blood. They're basically the body's first line of defense against sepsis coming from the gut.
Let's talk about bile and its recirculation, the enterohepatic circulation.
So bile is synthesized continuously, and it's composed of water, electrolytes, bilirubin, and bile salts. The bile salts are synthesized from cholesterol, and they are essential for fat emulsification. In enterohepatic circulation, these salts get released, they're used in the intestine, reabsorbed primarily in the distal ileum, returned to the liver via the portal system, and then secreted again. This really efficient recycling dramatically reduces the liver's need to synthesize new bile salts all the time.
And for our listeners preparing for pharmacology, the liver dictates drug availability through the first pass effect. This is a big one.
A very big one, yes. For many oral medications, absorption through the GI tract leads directly to the liver via the portal vein. So, if the drug is extensively metabolized by the liver before it ever reaches systemic circulation, its bioavailability is reduced. This first pass effect is why you often need a much, much larger oral dose for some drugs compared to the IV dose to get the same therapeutic effect.
Okay, so when liver function is impaired, the earliest sign is often jaundice.
Yeah, jaundice is the yellowing of the skin and sclerae, and it's caused by an abnormally high bilirubin concentration, which is a byproduct of hemoglobin breakdown. And the location of the problem dictates the type of jaundice. If you have a complete bile duct obstruction, for example, bilirubin can't reach the intestine for normal breakdown, and that leads to those classic clay-colored stools and an absence of urobilinogen in the urine.
And the most dramatic fluid complication has to be ascites, the accumulation of fluid in the peritoneal cavity.
Ascites results from a dual pathophysiology. It's a two-pronged attack. First, you have portal hypertension, which increases the hydrostatic pressure in the portal system. Second, the failing liver decreases its synthesis of serum albumin, which then lowers the plasma osmotic pressure, so fluid just leaks out into the peritoneal space.
So the management requires this rigid control over fluid and sodium.
Correct. Nutritional therapy begins with a strict 2-gram sodium restriction, as outlined in chart 43-3. Pharmacologically, spironolactone is the preferred diuretic.
Why spironolactone specifically? Why not a more powerful loop diuretic like furosemide?
That's a great clinical insight to highlight. Spironolactone is preferred because it's a potassium-sparing diuretic that also acts as an aldosterone antagonist. Patients with cirrhosis and ascites often have secondary hyperaldosteronism, which makes sodium and water retention even worse. So spironolactone directly counteracts that process, making it highly effective, whereas loop diuretics would just exacerbate volume loss and potentially cause hypokalemia, which complicates everything.
And for refractory or massive ascites, we turn to interventions, like a large volume paracentesis.
Yes, paracentesis is used diagnostically and therapeutically. A large volume removal, say 5 to 6 liters, requires a concurrent IV infusion of salt-poor albumin, and that albumin infusion is absolutely crucial because it helps maintain osmotic pressure and prevents post-paracentesis circulatory dysfunction, which can otherwise lead to rapid reaccumulation of ascites and possible acute kidney injury. The TPS procedure, the transjugular intrahepatic portosystemic shunt, that's reserved for patients with refractory ascites or uncontrolled variceal bleeding.
Okay, moving to the most dangerous complication of chordal hypertension bleeding, esophageal varices.
This carries an incredibly high mortality risk. The nursing priority is immediate stabilization, and there's a key clinical sequence that must be followed. Vasoactive drugs, specifically octreotide or vasopressin, must be given as quickly as possible before endoscopy. The reason is they can be administered faster than definitive procedures and they rapidly reduce portal pressure, which can stabilize the bleed.
Once the patient is stabilized, then endoscopy is performed. What are the definitive treatments?
The first-line endoscopic treatment of choice is endoscopic variceal ligation, EVL, or banding therapy. You can see it in figure 4310. A ligature, basically a small rubber band, is placed over the bleeding varix, which causes it to eventually slough off. Endoscopic sclerotherapy, injecting a thrombosing agent, is considered a secondary treatment now. EVL is preferred for both acute bleeding and for preventing rebleeding.
Next up, the neurological consequence of this synthetic failure, hepatic encephalopathy.
This is a complex syndrome, and it's associated with elevated ammonia levels. It's because the liver can't metabolize protein byproducts, and that leads to CNS dysfunction.
So what are the classic high-priority symptoms for the nurse to assess?
You're looking for changes in mental status, which can range from just subtle confusion all the way to a coma. You're looking for specific motor changes, including asterixis, that's the involuntary non-rhythmic hand flapping or liver flap. And you're looking for fetera hepaticus, which is a sweet, slightly fecal breath odor caused by mercaptans. Serial neurologic exams and even daily handwriting tests are crucial assessment tools.
Now, in managing this, there's been a significant evidence-based shift regarding protein restriction that really needs to be elaborated on.
This is a critical update for clinical practice. Management focuses on reducing ammonia, primarily by using lactulose to promote ammonia excretion. The goal is 2-3 soft stools daily. Historically, protein was severely restricted, but the crucial update is that severe dietary protein restriction is no longer routinely recommended. Evidence shows that maintaining adequate nutrition is vital. Protein intake should be maintained at 1.2 to 1.5 grams per kilogram per day, prioritizing nutritional status unless the patient is in a frank severe coma. The risk of malnutrition from the restriction often outweighs the benefit.
Okay, shifting to viral causes. Hepatitis. We need to differentiate the types and their long-term risks, which are in table 43-4.
Okay, so hepatitis A, HAV, and hepatitis E, HEV, are transmitted fecal orally. They usually result in an acute, self-limiting disease with recovery, and they do not lead to a chronic carrier state. On the other hand, hepatitis B, HBV, CHCV, and DHTV are transmitted parenterally, so blood or sexual contact, and they carry a significantly increased risk of progressing to chronic hepatitis, cirrhosis, and hepatocellular carcinoma.
The text highlights that despite blood screening, IV drug use remains a major driver for HCV.
That's correct. And for HBV, the sources emphasize that the widespread success of the HBV vaccine, alongside public health measures like universal precautions, has been the key driver in reducing acute incidence rates since the 1990s. So education regarding sexual health and substance abuse prevention is paramount in nursing.
And finally, acute liver failure, ALF, which is often caused by toxins.
ALF is the sudden severe impairment of function in a previously healthy person. It's characterized by rapid encephalopathy and a significantly elevated PTINR of 1.5 or higher, all within 8 weeks of jaundice onset. The most common cause is acetaminophen overdose. Management requires immediate ICU support, antidote administration, and acetylcysteine for acetaminophen and urgent assessment for transplantation.
Speaking of which, what are the nursing priorities post-liver transplantation?
The patient is going to require lifelong immunosuppression with drugs like cyclosporine or tacrolimus to prevent rejection. So the nursing priority becomes meticulous infection prevention. This means strict adherence to evidence-based bundles from organizations like the IHI, the Institute for Healthcare Improvement, ensuring rigorous sterile technique for central lines and drains to prevent infections like CLABSSI. A noteworthy detail, too. The sources mention that the live donor often experiences more post-operative pain than the recipient.
All right, moving on to Chapter 44, which details the interconnected biliary tract and pancreas. Started with gallstones, cholelithiasis, and inflammation, cholecystitis.
Right, so cholelithiasis, or gallstones, often leads to cholecystitis, which is inflammation, when a stone obstructs the outflow of bile, usually in the cystic duct. This causes bile stasis and then subsequent inflammation.
And the diagnostic and interventional tool of choice is often the ERCP.
Endoscopic retrograde cholangiopancreatography, ERCP, is key for visualizing the ducts and for treating cholelithiasis, that's stones lodged in the common bile duct. Because the procedure involves phytic sedation and manipulation of the ducts, the nurse has to monitor very closely post-procedure for potential complications, specifically perforation, bleeding, or notably post-ERCP pancreatitis.
And for surgical removal of gallbladder itself.
Laparoscopic cholecystectomy is the standard approach now. It's drastically shortened recovery time compared to the older open methods.
After the removal, what are the key nursing alerts that indicate a bile drainage obstruction?
You have to watch for right upper quadrant pain, nausea, vomiting, and, most clinically significant, the appearance of clay-colored stools. That's because the bile flow is blocked, preventing bilirubin from getting into the GI tract. The nurse would also watch for jaundice.
Okay, now for the pancreas. Acute pancreatitis is described as the crisis of autodigestion.
It really is. The pancreas starts to digest itself when its enzymes are prematurely activated inside the organ. This is usually triggered by gallstones or chronic alcohol abuse, and it ranges from a mild interstitial edematous pancreatitis to a severe necrotizing pancreatitis.
How does that present clinically? What does it look like?
The hallmark symptom is severe mid-epigastric pain, which often radiates to the back. This pain is unique because it tends to occur 24 to 48 hours after a heavy meal or significant alcohol ingestion, and crucially, it is unrelieved by antacids. The pain is often worse when the person is lying down and feels a bit better when they're sitting up and leaning forward.
And clinicians use scoring systems, like Ranson's criteria, to predict the severity.
Precisely. Chart 44-3 mentions using clinical and laboratory risk factors to predict mortality. The revised Atlanta classification grades severity into 3 categories: mild, no organ failure; moderately severe, transient organ failure; and severe, characterized by persistent organ failure. The high mortality of severe pancreatitis demands very aggressive management.
In acute management, what is the single most important early intervention for the pancreas itself?
The core immediate step is withholding all oral intake NPO status to inhibit pancreatic enzyme secretion and just rest the organ. For nutritional support during recovery, the nutritional gold standard is to use enteral feedings early whenever possible. Enteral nutrition is safer and it's better at preventing infectious complications than PN, parenteral nutrition, which is reserved only for patients who can't tolerate the enteral route.
And since the pain is so excruciating,
pain management is paramount. It necessitates the liberal use of parenteral opioids like morphine or hydromorphone. While there are some historical concerns about opioids stimulating the sphincter of Oddi, the modern consensus is that effective, frequent analgesia is the most essential aspect of care.
Okay, so let's contrast that acute scenario with chronic pancreatitis.
Chronic pancreatitis is a progressive, destructive disease that causes calcifications and chronic pain. The management focus shifts entirely to long-term pain control and prevention of attacks. The approach to pain uses the WHO's three-step ladder. You start with non-opioids, you incorporate adjuncts like antioxidants, and then you introduce opioids very cautiously because of the high risk of abuse in this patient population. For intractable pain, an EUS-guided celiac nerve block is an option.
And what's a non-negotiable patient education point for that?
Absolutely. Total avoidance of alcohol and any known trigger foods. The patient has to understand that pain relief is virtually impossible if they continue to drink alcohol.
Finally, let's touch on pancreatic cancer. This diagnosis is often very advanced upon presentation.
Yes, it often is, because the symptoms are so vague until the tumor causes an obstruction. Tumors in the head of the pancreas are particularly likely to obstruct bile flow, and that leads to those classic signs: jaundice, pain, and clay-colored stools. Management involves either the very complex Whipple procedure for resectable tumors or palliative measures.
So what are the lifelong nursing education needs for someone post-Whipple?
The post-op care is incredibly complex. The patient needs careful management of potential malabsorption and hyperglycemia. This means adherence to a low-fat diet, lifelong pancreatic enzyme replacement therapy that they have to take with meals to aid digestion, and often management of new onset or worsening diabetes because you've removed insulin-producing tissue.
All right, now we move to the final section. The master hormonal controllers, starting with the pituitary gland. How do these tumors impact the body?
Pituitary tumors are mostly benign. You have functional tumors, which secrete excess hormones. For example, basophilic tumors secrete way too much ACTH, and that leads to features of Cushing's syndrome. Then you have chromophobic tumors, which are the majority, about 90%. They destroy the rest of the gland, causing hypopituitarism, which manifests as obesity, somnolence, thin hair, and a profound hypometabolism. The definitive treatment is surgical removal via hypophysiology.
The posterior pituitary manages our fluid balance via ADH, antidiuretic hormone, and that leads to two diametrically opposed disorders: diabetes insipidus, DI, and SIADH. Let's define DI first.
Diabetes insipidus, or DI, is a deficiency of ADH. Without ADH, the kidney just cannot conserve water. This results in massive polyuria, often greater than 250 milliliters per hour of extremely dilute urine. The specific gravity is like 1.001 to 1.005, and the resulting intense thirst leads patients to drink 2 to 20 liters of fluid a day. It's unbelievable.
And the management for that.
The goal is simply ADH replacement. The drug of choice for central DI is desmopressin, which is a synthetic form of ADH. Fluid restriction is strictly contraindicated. It will only lead to severe hypernatremia and dehydration without changing the massive fluid loss from the kidneys.
Okay, now for the complete opposite, SIADH.
Syndrome of inappropriate ADH, SIADH, is caused by excessive ADH secretion, which leads to water retention. The underlying cause is often non-endocrine, like bronchogenic carcinoma, and that fluid retention results in dilutional hyponatremia, meaning the sodium concentration is low just because of the excessive water volume.
So the management strategy just flips entirely from DI.
Absolutely. Treatment for SIADH focuses on strict fluid restriction and eliminating whatever the underlying cause is. The restriction allows the body to excrete the excess water and slowly correct that dilutional hypernatremia.
Moving down to the thyroid gland, let's start with hypothyroidism.
Hypothyroidism, so suboptimal thyroid hormone, often from Hashimoto disease, slows all the body functions down: fatigue, weight gain, cold intolerance. Management is lifelong replacement with synthetic levothyroxine.
What's the critical cardiac monitoring priority when you're initiating levothyroxine?
The nurse has to closely monitor older patients or those with pre-existing heart disease for any signs of cardiac dysfunction, especially angina or arrhythmias. Levothyroxine increases the metabolic rate and the heart's sensitivity to catecholamines. So you might need to reduce the thyroid hormone dosage immediately if cardiac symptoms appear.
And conversely, hyperthyroidism, often Graves' disease, speeds everything up.
Yes, and this results in anxiety, tremor, restlessness, tachycardia, and exophthalmos, which is the protruding eyes. The great risk here is thyroid storm, which is a life-threatening crisis of extreme hypermetabolism. Beta blockers are used adjunctively to manage the tachycardia and tremor.
And post-thyroidectomy, we worry about rapid calcium changes.
That's right. If the parathyroid glands are accidentally injured or removed during surgery, the patient can develop rapid hypocalcemia. This causes tetany hyperirritability, muscle twitching, spasms, which can progress to a life-threatening laryngospasm. The immediate intervention is IV calcium gluconate.
Let's briefly cover the parathyroid disorders.
So hyperparathyroidism causes hypercalcemia, which results in bone decalcification and renal calculi or kidney stones. Management requires hydration, at least 2,000 millimolars a day to prevent stones. An acute hypercalcemic crisis needs aggressive intervention with calcitonin and corticosteroids.
Next, the adrenal glands, which govern our stress response. Let's talk adrenocortical insufficiency, or Addison's disease.
Insufficient steroid production. This leads to hypoglycemia, muscle weakness, and, diagnostically, hyperpigmentation due to a compensatory increase in ACTH. The critical danger is the Addisonian crisis, severe hypotension and shock triggered by stress, which requires aggressive fluid and steroid replacement. These patients need lifelong glucocorticoid and mineralocorticoid replacement, and they have to be educated on increasing their dosage during times of physical stress.
Now let's contrast that with Cushing's syndrome, or steroid excess.
Cushing's results in that classic triad: truncal obesity, a buffalo hump, and a moon face, coupled with thin skin and severe glucose intolerance. The diagnosis requires abnormal levels across multiple tests: serum cortisol, urinary cortisol, and the low-dose dexamethasone suppression test.
And the crisis of pheochromocytoma.
That's an adrenal medulla tumor that causes this massive life-threatening release of catecholamines, epinephrine, and norepinephrine, and it results in severe episodic hypertension. The preoperative management is crucial. The patient must receive alpha and beta blockade before surgery to prevent a fatal hypertensive crisis.
Okay, we've saved the most voluminous and clinically significant topic for last. Diabetes mellitus from Chapter 46, Managing the Ultimate Metabolic Crisis.
Right. The foundation of diagnosis relies on the fasting plasma glucose, FPG, and the HbA1c, which is a measure of average glucose control over 3 months. And we have to recognize not just type 1 and type 2, but also prediabetes, which is impaired glucose metabolism, presenting as a significant risk factor.
Nutritional management, or MNT, is absolutely key. What are the distribution goals?
The focus is on caloric distribution, 50 to 60% carbohydrates, less than 30% fat. The goal is consistency. The text compares carbohydrate counting, which allows for flexibility but requires a high skill level, with the simpler My Plate food guide, which, while it's easy to teach, can lead to less predictable glucose control because it treats all carbohydrates the same.
Insulin therapy aims to mimic normal secretion, so basal and bolus.
Correct. You have intensive regimens, which are 3-4 injections a day or an insulin pump, and they offer flexibility and better long-term outcomes. Then you have conventional regimens, which are simpler but demand a really rigid meal and activity schedule from the patient.
Now, the acute hyperglycemic crises, DKA, diabetic ketoacidosis, and HHS, hyperglycemic hyperosmolar syndrome. They both share hyperglycemia and dehydration, but the core distinction is the presence of acidosis in DKA.
That's the key. DKA results from the absolute absence of insulin. This forces the body into lipolysis, producing acidic ketone bodies, and that results in acidosis, which gives you that fruity breath. The management sequence is very specific: rehydration, with 6 to 10 liters of fluid being common, then potassium replacement, because levels drop rapidly when insulin starts working, and finally a continuous insulin infusion to stop the ketosis.
This is where we need to highlight a specific danger in DKA management: dropping the blood glucose too fast.
That is a critical alert, yes. While the insulin is infusing, we must switch the IV fluid to a dextrose-containing solution, like D5NS, when the blood glucose drops to the 250 to 300 mg/dL range. If you let the glucose drop too rapidly, that rapid osmotic shift can cause potentially fatal cerebral edema. So we slow the insulin, we don't stop it, to allow the ketosis to resolve safely while we maintain the glucose above 250.
And what about HHS? How is that different?
HHS, hyperglycemic hyperosmolar syndrome, results from inadequate insulin, and it's usually in type 2 patients. There is just enough insulin to prevent lipolysis and ketone production, so there is NO acidosis. However, the hyperglycemia is extreme, often over 600 mg/dL, and it causes this profound, life-threatening dehydration and high serum osmolality. The mortality is actually higher than with DKA.
So the management priority is completely distinct.
Completely. Because there is no acidosis to reverse, massive fluid replacement is the absolute #1 priority to correct the profound dehydration and hyperosmolality. Insulin plays a much less important role than it does in DKA, as rehydration alone often corrects a lot of the glucose elevation. Fluid monitoring is critical here, especially in older patients, to prevent fluid overload and heart failure.
And finally, the lifelong challenge: the chronic complications.
Starting with diabetic retinopathy, which is the leading cause of blindness, we differentiate non-proliferative from proliferative retinopathy. And proliferative is the greatest threat because you have the growth of these fragile new vessels that are prone to bleeding.
And the diabetic neuropathies.
They fall into two major types. You have peripheral sensoromotor neuropathy, which affects the extremities. It causes pain and that dangerous loss of sensation, the insensitive foot. And chronic loss of proprioception can lead to deformities like Charcot joints.
But the autonomic neuropathies are particularly insidious, aren't they?
They are. Autonomic neuropathy affects systems the patient doesn't control. It can cause gastroparesis, a neurogenic bladder, and the most frightening complication in terms of glucose control, hypoglycemic unawareness. Because the neuropathy damages the adrenal medulla, the patient loses the typical adrenergic warning signs of low blood sugar, the tremor, the sweating, the palpitations, so they can become severely hypoglycemic without any warning signal at all.
Which makes nursing assessment and prevention of foot injuries a paramount, daily priority.
It is absolutely essential. Because of the insensitive foot, daily inspection is mandatory. The nurse uses the monofilament device to test for loss of protective sensation, which is a key assessment framework outlined in the sources. And education must stress avoiding self-medication for calluses and preventing any thermal, chemical, or traumatic injury to avert ulceration and eventual amputation.
Wow. That was an incredible journey. We have synthesized a massive body of knowledge, moving sequentially from the chronic relapsing metabolic disease of obesity all the way through the acute complexities of hepatic failure and portal hypertension. We navigated the self-destructive crises of acute pancreatitis, and we finished by detailing those immediate, nuanced management differences between DKA and HHS.
The central synthesis of this unit is really clear. Mastery in medical surgical nursing means recognizing how all these specialized areas are deeply, deeply intertwined. Managing ascites effectively prevents a variceal bleeding. Managing chronic diabetes prevents neuropathic ulcers. And recognizing that insufficient steroid replacement can lead directly to an Addisonian crisis. That's the essence of connecting these systemic dots.
And we've seen time and again that stress, whether it's physical stress from infection or surgery, or severe emotional stress, is the common, dangerous, precipitating factor for acute collapse across all of these systems.
Yeah. And for the learner listening, I think the ultimate challenge isn't just knowing the lab values or the procedural steps. It's developing the clinical intuition to recognize when physiological or emotional stress is about to breach that delicate homeostatic balance. What are the earliest non-obvious signs? The subtle, persistent nausea in a patient with a history of pancreatitis? Or the slight but consistent increase in heart rate in a compensated cirrhosis patient? Or even the change in sleep pattern in a stable diabetic? That signal the need for a preactive intervention to prevent an acute systemic collapse.
Recognizing and intervening at that subtle shift, that's the true mark of expertise. Thank you for joining us on this deep dive. We hope this masterclass helps you connect the dots and apply this core clinical wisdom in your practice.
Apply this knowledge well, and we'll catch you next time.
Until then.